want to talk to you today about total knee replacement. We've done your history, physical exam, and x-rays, and we've decided that you are a good candidate for knee replacement surgery. This is a major procedure. It has one of the highest patient satisfaction rates. It is not as high a patient satisfaction as total hip replacement, but it's not far behind. And it is used for the treatment of pain secondary to arthritis of the knee. And with pain relief in mind, it has very good success. It is not as reliable for range of motion and strength as it is for pain relief. This procedure is typically done under a spinal anesthetic with varying degrees of sedation per patient preference. And we do it through a direct anterior approach straight down the front of the knee to expose the joint. This procedure is done computer assisted, and that implies that we place pins. There are 2 pins placed just above the knee in the distal femur, and there are 2 pins placed just below the knee in the upper tibia. They're positioned percutaneously out of the way of our open procedure for total knee replacement. And attached to those pins is a 3-dimensional array on the XYZ axis of reflective spheres. We have an infrared camera that allows us to digitize the surface of the joint, both the femur and the tibia, and then create a model of the joint. We're actually able to calculate the center of rotation of the hip by rotating the femur through a cone, and then by triangulation can calculate that center of rotation. And we define the center of the ankle by identifying both the medial and lateral malleoli at the ankle and calculating the center of the talus. After registration, the knee is taken through a range of motion, and we apply a varus and valgus stress through range of motion, and we can identify the degree of laxity both on the medial and lateral side of the knee, and this is quantitated as a visual image on the computer screen so that we can both feel the laxity and see the laxity, and this comes into play in our decision making for the replacement. We then perform the proximal tibial cut based on planning the varus valgus neutral angle, slight slope, level of the cut, and the computer is used to guide the cut, guide the placement of the jig, and then we make the cut, and then we verify the cut using the computer. At this point, we make sure that the knee is well aligned. We bring the knee into a neutral posture, and we do any soft tissue releases that may be required to bring the knee back to neutral alignment. We then register the extension gap. That's the gap between the femur and the tibia in extension once it's properly aligned. And then we measure the gap in flexion. Now, having done those releases, that may affect the gap, and it may be necessary in order to get a nice rectangular gap that is equal in both flexion and extension. It may be necessary to slightly rotate the femoral components so that there is good symmetry between the medial and lateral side. We want pure rectangular gaps and not trapezoidal gaps where there's a mismatch and a lack of balance. The computer allows us on the femoral planning screen to define the exact parameters that are necessary in terms of femoral position, both distally and proximally, anterior and posteriorly, and rotationally. And if you really think about it, there are 6 degrees of freedom for each of the components of the knee. And the computer helps to be sure that we are planning our cuts to be in the appropriate position and posture for each of the components. At one point, we considered going to patient-specific instrumentation and patient-specific implants, which are based on preoperative CT scans and or preoperative MRI, and the definitive implant is defined, but this does not address the soft tissue element of the procedure. And so doing this optimized approach using the computer, we can make adjustment based on the individual patient's anatomy, the patient's soft tissue, their soft tissue balance, so that we can create that balanced extension and flexion gap, both medially and laterally, so that they're all equal in dimension. So with the femoral planning screen, we define the position of the femur, and the computer then guides the placement of the cutting jigs so that we meet the appropriate parameters. We make the cut, and then the computer verifies the cut to be sure that it's what we intended. And once we've completed all of the cuts, we do a trial reduction. And again, we take the knee through a range of motion, and we can look at the stability, the correction of the alignment, the correction of the stability, and the balance of the joint. And this is all visually displayed on the computer monitor, and adjustments are made throughout the procedure based on both the tactile but also the quantitative information in half-millimeter increments and half-degree increments for each of the parameters that we're looking at. So the computer doesn't do the operation, but it helps to make us more accurate as we perform the procedure. And there are numerous studies that have shown the improvement in accuracy. We've been using the computer since 2005, and it is just a tool, but a very effective tool in improving outcomes. The procedure takes a couple of hours to do. There is some setup time at the start, additional time in recovery, with x-rays and orders and dictating operative note. So it will be longer before I have a chance to speak to your family, closer to 3 hours before I will be out to speak to family in the waiting area. In terms of blood loss in the setting of total knee replacement, the majority do not need a transfusion. We do allow the hemoglobin to drop down to about 8 and the hematocrit down to about 24 before we add a transfusion, but there are patient factors and medical factors that are weighed which may alter our threshold for transfusion. But typically it's less than 10% will require a blood transfusion after the knee replacement. As far as weight bearing goes, the components are cemented into place: femoral component, tibial component, and patellar components. And so weight bearing is permitted immediately after surgery. It is full weight bearing as tolerated, and this would only be modified in the event of specific patient pathology, but the vast majority are full weight bearing. Discharge home is based on achieving certain discharge criteria. Many patients are ready for discharge home the following day, but you can't be discharged until you have demonstrated the ability to get in and out of bed, ambulate independently with a walker, get back and forth from bed to bathroom, on and off the toilet, and ambulate in the hall. You will also need to demonstrate proficiency, or at least the ability to negotiate stairs, particularly if you have stairs at home. If you do not have stairs at home, it is still worth learning how to negotiate stairs before discharge. You'll also have to have stable vitals that are within the normal range, and blood work will have to meet appropriate discharge parameters. And that seems like a long list of criteria to be able to be discharged, but many people are ready for discharge the day after surgery. Some people will need an additional day before being discharged home. We want to be sure that you have appropriate pain control on oral medication. And we will provide pain medication on discharge, and we'll provide those prescriptions based on what we found works for you while you're in hospital. Typically, that would involve mild, moderate, and severe pain medication. We use Tylenol as mild, Tramadol as moderate, and for severe pain, oxycodone. And these aren't used separately, but are used additively or together. So for baseline, we'll have you use 2 Tylenol and 2 Tramadol 4 times a day. Clearly, this would be adjusted based on age, weight, and tolerance to medication. But the majority would use 2 Tylenol and 2 Tramadol 4 times a day, T2, T2. The Percocet is for severe pain. Percocet is a combination of Tylenol and oxycodone. So instead of using Percocet, we'll use pure oxycodone, which allows us to separate the Tylenol from the oxycodone. And that way you can use full dose Tylenol, which may allow you to use less of the oxycodone. And at the upper end, if you need to use additional oxycodone, you can do so, and you're not limited by the presence of Tylenol in the prescription. The goal of the pain medication is not to bring the pain to 0, but to bring the pain down to a manageable level. So if the pain is a 1, 2, or 3 on 10, I would be disinclined to add the oxycodone. But if it's a 5, 6, or 7 on 10, I would certainly add it. I wouldn't wait till it's an 8, 9, or 10 on 10, because it's easier to keep under control than it is to get back under control. You'll only use the the oxycodone for a short period of time, and then as the pain improves, you'll wean off the oxycodone and then start tapering down on the Tramadol. When you are taking Tramadol and or oxycodone, they are both narcotic pain medications that cause side effects. And if you take too much, it will cause drowsiness and lethargy. And even on routine doses, it will cause some degree of constipation. So I'll provide you with a prescription for a stool softener, Ducosate, which is the same as Colace. You'll take it twice a day until you're no longer taking narcotic pain medication. If the stool softener is not sufficient, you can use Senna, which is a laxative, to help keep you regular. But you should be aware of that side effect of the narcotic pain medication. In addition, I will provide you with an anti-inflammatory, typically Celecoxib, which is the same as Celebrex, 200 milligrams daily. An alternative would be over-the-counter Aleve, 2 tablets, twice a day with food. And you'll use the anti-inflammatory for the first 2 months post-operatively. In addition, I will provide you with baby aspirin. That's 81 milligrams of the enteric-coated aspirin, and you'll use that for the first 2 months as part of DVT prevention. And we discussed DVT in the risks and complications video, but you'll use the combination of aspirin and these sequential compression devices, the home VenaPros, for your DVT prevention. These are SCDs, or sequential compression devices, that are rechargeable, battery operated, that you'll use for the first month at home. You'll use them when you're up, when you're not up, when you're seated or lying or sleeping, and you can take them off when you're up ambulating. As far as your physical therapy is concerned, if you have surgery on a Monday, let's say, you go home on a Tuesday, you'll start outpatient physical therapy on the Friday, and this will help to work on decreasing pain and swelling, improving range of motion, strength, and function. And the physical therapist will guide you through your post-operative rehabilitation program. You will attend physical therapy more frequently at first, and as you're improving, you'll decrease the frequency and progress to a more independent home exercise program. Rehabilitation for the total knee replacement takes 2 to 3 months. There is improvement for out to a year, but the main rehabilitation time is in the first 3 months. Our goal is to achieve full extension and 120 degrees of knee flexion. The ultimate knee range of motion is variable, but this will be your goal. The preoperative range of motion is one of the major determinants of postoperative range of motion. So if you had significant preoperative knee stiffness and loss of motion, you may not achieve our goal, but you should still work toward the goal of 0 to 120 degrees. At this point, you will have normal function going up and down stairs. If you have less flexion, you may find some difficulty, particularly going downstairs. Strengthening is an important part of your rehabilitation, and particularly getting the quadriceps strength through straight leg raise exercises and terminal extension strengthening exercises. The more you do to work on your range of motion and strength in the early phase, the better your ultimate function will be in the long haul. Occasionally, patients are having difficulty achieving their range of motion, and in a small percentage of patients it may be necessary to consider a manipulation under anesthesia. This occurs in 1 or 2% and is typically done somewhere between the 2 and 3 month mark if the motion is not showing progression toward our goal. This video is predominantly to give you a sense of what's involved with the knee replacement and the rehabilitation. I would like to add that everybody with total knee replacement will have some numbness on the lateral side of the knee. That's because the innervation comes from the medial side, and so there will be altered sensation on the outer side of the knee. Only 50% of total knee replacements are finding that they are comfortably able to kneel. This isn't me telling them not to kneel, it's because they would prefer not to kneel on their knee. If you can comfortably kneel, it's okay to do so, but only about 50% will be regularly kneeling. The other thing is that early on you will have a sense of muscular weakness and you will have a limp. Those will gradually improve over time. Finally, I wanted to mention the survivorship curve. Total knee replacement is a successful operation, but it is a mechanical device, and it does have a propensity for wear. Wear is based on age, weight, and activity level. The younger, heavier, more active the patient, the greater the potential for wear. And I like to use the analogy of the tires on your truck. If you put 30,000 miles a year on it, it's more likely to wear than if you put 10,000 miles a year. But eventually, total knee replacements may fail. Mechanisms of failure include wear, loosening, fracture, dislocation, instability, patellofemoral problems, infection, and pain. And if you add up all of those potential modes of failure, it still has very good success. At 5 years, it's still 95% successful. By 10 years, it's about 80 to 85% successful. By 15 years, it's about 2/3. And by 20 years, up to half have required revision. So total knee replacements don't last forever. You have learned how to treat your knee kindly while you're trying to manage the pain of your osteoarthritic knee. When we eliminate the pain with your knee replacement, I don't want you to forget how to treat your knee kindly, which will help you to maintain longevity. The knee replacement is made to walk, bicycle, swim, hike. Going to the gym to do workouts for stretching and strengthening are all appropriate, but it is not made to run, jump, kick, or for heavy pivotal activity. Treat your knee replacement well, and it should last you for many years. I would like to introduce you to our total joint coordinator. We attempt to anticipate your postoperative needs, and we have an entire binder of information which I would like you to read. In fact, I'd like you to read it twice so that you have a good familiarization of the procedure and what to expect. I'm just one part of an entire team that is dedicated to trying to get a good outcome for your total knee replacement. In addition to my office staff and our total joint coordinator, when you go to the hospital, there are nursing staff in the pre-surgical area, nursing staff in the operating room, recovery room, and dedicated staff on the medical surgical unit during your initial recovery. We'll arrange your outpatient physical therapy, and following through with your home exercises is key to the outcome. The other thing is a good positive attitude. A positive attitude is fostered through understanding the nature of the procedure, having a comfortable knowledge of what to expect, and this can lead to you feeling more relaxed and more confident in the process. That can lead to a positive attitude that contributes to a good positive result. This short video is to give you a sense of what total knee replacement is about. It raises questions, and if you do have any questions, I'd like to go over those with you. And when you leave, if you have further questions, please don't hesitate to contact us, and we'll be sure to get back to you with the answers.